Hope I'm audible. If you have any doubts, you can post it in the comment section. We'll take them at the end. So right now we'll begin. So yesterday we had completed, if you remember, we had completed about the basic phaeochromocytoma workup. So we already saw that whenever you are diagnosing any condition, we have seen the criteria of BLS, that is basic life support. First you are going to go for a biochemical test, then you are going to go for a localization. After stabilizing the patient, you are going to take him for the OT. So on the similar terms, what you are going to do here is, after you are going to get a patient of phaeochromocytoma, most of the times he is going to present with clinical features like headache and hypertension. So after you are going to diagnose the patient, you are going to think about the diagnosis. You are going to go for the biochemical testing, which is going to be 24 hours metanephrines. We saw that why to go for 24 hours metanephrine rather than taking plasma metanephrine levels, because urinary metanephrines are going to be there collectively of the 24 hours. So a patient might be anxious while meeting you, he might have high plasma adrenaline, and that is the time when you can diagnose him as falsely elevated phaeochromocytoma. So many times plasma metanephrine levels are not that great. So always consider taking 24 hours urinary metanephrine levels. The same thing which we used to do, if you remember, even in the parathyroid, we talked about 24 hours urinary calcium and not the spot calcium. So very much important for you to know. So after you are going to go for 24 hours for urinary metanephrines and your catecholamines, the first chemical bio, it is going to be 90% sensitive. After that, you are going to go for imaging. Plasma plus urine. After doing that, you are going to go for imaging. In the imaging, you are going to go for 2 scans which were present. So rightly given in the flow chart. So after you are going to, so in any patient of phaeochromocytoma, if the patient is going to present to you with palpitations and headache, you are going to go for 24 hours urinary film metanephrines and fractionated metanephrines. Sir, why only urinary? Because we saw that 24 hours total जितना यूरिन में कलेक्ट होने वाला है उतना दिखने वाला है. वो पॉइंट पे अगर मेटानेफ्रिन ज्यादा है तो फॉल्सली एलिवेटेड भी दिख सकता है. इसलिए 24 hours urinary metanephrine is very much important. After you are going to confirm the diagnosis, this is going to be the B portion of your endocrinology. Then the localization, you are going to go for 2 imaging. So initially we saw that MIBG scan was used. MIBG used to use the iodine tracer, but we saw that when you are going for an MIBG scan, there was sometimes a problem with the uptake. So there is a new scan which has come up for all the neuroendocrine tumors, that is going to be your gallium DOTATATE scan. So it is a new scan which has come up. So it is going to help you localize the tumor. After you are going to localize the tumor, before taking the patient for the OT, you are going to go for stabilization of the patient. Always remember that alpha blockage followed by beta blockage, because we know that beta 2 is going to cause vasodilation. So अगर beta पहले block करोगे तो naturally क्या होगा, अचानक से patient का vasodilation भी बंद होगा. So there will be hypertensive crisis. So always alpha blockage first. Alpha blockage कौन सा यूज करने का? We used to use the phenoxybenzamine. We saw that 10 mg tablet चालू करने का, step up to 40 mg. Target BP कितना होना चाहिए? Target BP should be 130/80 and heart rate should be around 60 to 80. We also saw few clinical signs. Patient को postural hypotension होगा, nasal stuffiness होगा, because alpha blockage is not working properly, but it is a sign that it is going to be adequate blockage. And after that you are going to post the patient for surgery. Always remember, हमने पहले ही adrenals में देखा हुआ है कि if less than 6 centimeter का कोई भी tumor है, and if you are not thinking of a malignancy, you can go for a laparoscopic surgery. But if you are going for more than 6 centimeter tumor, you are going to go for an open adrenalectomy. So few things which we already saw, that when you are going to manage the patient, when you are going to manage the patient, resuscitation, the resuscitation, you are going to give high salt and fluid intake. We already saw that the highway is going to be narrow. So when the highway is going to be narrow, naturally the vehicles are going to reduce. So that is the problem. The patient's blood volume is already contracted because of intense vasoconstriction. इसलिए तुम patient को क्या दोगे? High salt diet with, you are going to give proper fluid so that the intravascular volume is restored. उसके बाद में whenever you are going to go for surgery, always remember that laparoscopic prefer for less than 6 centimeter tumors. समटाइम्स अगर कुछ लोग बोलते हैं कि अगर 10 सेंटीमीटर तक बढ़ा है तो भी कर सकते हैं, बट अकॉर्डिंग टू द बुक्स इट इज गोइंग टू बी द 6 सेंटीमीटर्स गाइडलाइन. ओपन एड्रेनलेक्टमी फॉर मोर देन 10 सेंटीमीटर ट्यूमर्स, एंड वी ऑलरेडी सॉ दैट 10 सेंटीमीटर के ऊपर पेशेंट का नेचुरली मैलिग्नेंसी का चांसेस आर गोइंग टू इंक्रीज. सो वेरी मच इंपॉर्टेंट फॉर यू टू नो. अगर मैलिग्नेंसी सस्पेक्ट कर रहे हो तो मॉर्टेलिटी इज वेरी हाई. वी सॉ दैट कुशिंग सिंड्रोम में 50% ऑफ द पेशेंट्स विद मास एंड कुशिंग सिंड्रोम आर गोइंग टू बी मैलिग्नेंट. इधर मैलिग्नेंसी का चांस फिर भी कम है, बट हियर सर्जरी इज द बेस्ट पैलिएशन. क्यों पैलिएशन? बिकॉज सर्जरी करने के बाद में एटलीस्ट उसके सिम्टम्स कम होंगे. द एड्रेनालिन विच इज हाई इज गोइंग टू रिड्यूस. सो एनी एंडोक्राइन ट्यूमर, इवन डूइंग अ सर्जरी, इवन इट माइट नॉट बी क्यूरेटिव इंटेंट, इवन इट माइट बी अ पैलिएटिव इंटेंट, बट दैट सर्जरी इज गोइंग टू बेनिफिट द पेशेंट, बिकॉज आफ्टर डूइंग दैट सर्जरी नेचुरली द पेशेंट के हार्मोन्स कम होंगे एंड पेशेंट का प्रॉब्लम कम होगा. एंड वेन एवर यू आर डीलिंग विद द सिंड्रोमिक complications, or if there are bilateral tumors, you can go for bilateral adrenalectomy. But इधर patient को वापस Addisonian crisis होगा, उसी को हम लोगों ने कल बोला था, the patient might have what is called as Nelson syndrome. So Nelson syndrome is very much important, and here you will have to go for cortisol sparing approach. Partial adrenalectomy भी तुम कर सकते हो, बस medulla निकाल सकते हो, but it is highly specialized surgery, so normally you can go for bilateral adrenalectomy. Sir, where did we not go for bilateral adrenalectomy? In Conn syndrome. So in Conn's, never go for a bilateral adrenalectomy. It can be managed very well with the oral medications. But when you are going to go for, but what is the thing? But when you are going to manage the patient, of Cushing's, so that is the time when you can actually go for a bilateral adrenalectomy, which is going to be justified. So I hope it is clear. So now there is a small topic of congenital adrenal hyperplasia. So it is an autosomal recessive, most common disorder. Problem क्या रहता है? 21 hydroxylase deficiency in 95% of the cases. It is typically explained properly in your pediatrics section, क्योंकि उधर तुम लोगों को different types of congenital adrenal hyperplasia based on the sex determination होता है. But basic point इधर क्या surgery के वास्ते you have to remember that 21 hydroxylase deficiency, patient को cortisol कम होने वाला है, aldosterone भी कम होने वाला है, and ACTH will be very much high. So here the patient might have bilateral adrenal hyperplasia. But despite adrenal hyperplasia होके भी hormones patient के कम है. So here there is not going to be a tumor. It is going to be high ACTH but low levels of your all the hormones. क्लासिकल में क्या दिखेगा? सो क्लासिकल में देयर इज अ सॉल्ट वेस्टिंग क्राइसिस इन द नियोनेट्स. क्यों? क्योंकि एल्डोस्टेरोन नहीं है, तो नेचुरली सोडियम इज गोइंग टू गेट वॉश्ड ऑफ फ्रॉम द यूरिन. इट इज गोइंग टू कॉज डायूरेसिस एंड इट इज गोइंग टू कॉज प्रॉब्लम्स. एंड नॉन क्लासिकल में क्या है? तो इट माइट बी एसोसिएटेड विद सेक्स हार्मोन्स एक्सेस बिकॉज द कॉर्टिसोल इज नॉट फॉर्मिंग. दीज आर गेटिंग डाइवर्टेड टू द सेक्स हार्मोन्स. सो नेचुरली प्रीमैच्योर मेनार्ज, हिर्सुटिज्म, मेंस्ट्रुअल इरेगुलरिटी एंड फर्टिलिटी इन फीमेल्स. दैट इज गोइंग टू बी द इश्यूज व्हिच आर गोइंग टू कम. क्या करोगे? तो यू आर गोइंग टू डायग्नोज द 17 हाइड्रोक्सी प्रोजेस्टेरॉन लेवल्स. क्यों ये बढ़ेंगे? क्योंकि 17 हाइड्रोक्सी प्रोजेस्टेरॉन इज गोइंग टू गेट कन्वर्टेड into the 21 hydroxyprogesterone with the help of this enzyme which is called as 21 hydroxylase. तो ये enzyme अगर नहीं है तो उसका substrate ज़्यादा होगा. So this substrate is going to be high. So it is very much important. And treatment is going to be lifelong glucocorticoid supplementation. Because this patient is not having the enzymes to produce the glucocorticoids, you are going to give lifelong supplementations. There might be salt wasting. अगर salt wasting है तो we know that we should replace what is called as the aldosterone, and aldosterone replace करने का hormone है fludrocortisone. So you can give fludrocortisone and you can replace the hormone. So it is very much important. Surgery, always remember that you can go for what is called as feminizing genitoplasty in the virilized females. So many times क्या होता है? Females को समझता नहीं है. Females को समझता ही नहीं है. मतलब it is portrayed as a false male but it actually is a female. मतलब क्या? तो patient के अंदर के सब hormones जो है, अंदर का सब architecture है, it might be of the female and the patient is falsely portrayed as a male, or the female might have virilization because of which excess testosterone she might develop a clitoromegaly, and that is the reason she might be falsely perceived as a male since the childhood. So that is the time when you can go for a conversion surgery, but timing is always controversial because child को जैसे ही अपना gender समझ में आने लगता है, that is the time when you can go for the surgery. So before that the child should undergo surgery. Very much important. So what is adrenal insufficiency? Whenever the adrenal hormones are not enough. So what are the types of adrenal insufficiencies? It might be destruction of the adrenal cortex because of which autoimmune destruction होता है most of the patients में, or it might be associated with TB, hemorrhage, and there might be a bilateral adrenalectomy which a surgeon might have done because of which there is going to be a primary Addisonian crisis. क्या क्या दिखेगा? Cortisol is going to be low, aldosterone low, and ACTH obviously going to be high. It is also that is called as hyperpigmentation, which is nothing but Nelson syndrome. So you should know this. Secondary में क्या दिखेगा? तो secondary में the problem is with the pituitary. ACTH secrete नहीं होने वाला है, and that is the reason patient के hormones कम रहने वाले हैं. So pituitary and hypothalamic failure, so less ACTH, less cortisol, and but aldosterone is going to be intact and no hyperpigmentation is going to be seen. Addisonian crisis. So what happens is there is a syndrome, if you had studied, because of meningococcal bacteria, because of meningococcal meningitis or sepsis, there is a syndrome which is called as Waterhouse Fredrickson syndrome. सर इस syndrome में क्या होता है? So naturally what happens is there is going to be adrenal hemorrhage, and adrenal hemorrhage होने के कारण adrenal gland is going to get self-destructed, or it might be also destructed during the time of trauma or emergency surgery or abrupt steroid withdrawal. So patient को क्या क्या दिखने वाला है? Patient को naturally automatically all the syndromes we have already discussed how the patient is going to present with acute adrenal insufficiency. Waterhouse-Fredrickson syndrome, it is a bilateral adrenal hemorrhage in meningococcal sepsis, and there might be purpura rash and cardiovascular collapse. Because there are no catecholamines, no proper sympathetic parasympathetic control, the patient is going to land up into what is called as a circulatory collapse. So very much important for you to know. How are you going to manage the adrenal crisis? So always remember, it is an acute condition. Steroid कम है patient को, patient is not able to deal with it, so you are going to give what is called as hydrocortisone 100 mg stat. So hydrocortisone 100 mg stat देने का, and उसके बाद में you are going to give 50 mg IV. Always remember, whenever you are taking a patient for surgery who is a known case of steroid dependence, so किसी भी patient को more than 5 mg of steroid, 5 mg of Visolon अगर tablet patient को, prednisolone more than 5 mg अगर patient को चालू है, तो you should always and always go for what is called as a steroid supplementation during surgery. So during crisis you are going to supplement the patient with 100 mg hydrocort. So कभी भी पेशेंट को जब सर्जरी के लिए लेना होता है, द पेशेंट इज ऑन स्टीरॉइड डिपेंडेंस, द पेशेंट इज हैविंग सम ऑटोइम्यून कंडीशन जिसकी वजह से उसको स्टीरॉइड डिपेंडेंस है, तो दैट इज द टाइम व्हेन यू आर गोइंग टू टेक द पेशेंट ऑन, दैट इज द टाइम व्हेन यू आर गोइंग टू टेक द पेशेंट ऑन, yes, give 100 mg hydrocort at the time of induction to manage the stress. Aggressive fluid resuscitation is important. Correct the hypoglycemia, because we saw that cortisol is going to increase the sugar levels, तो इस पेशेंट में hypoglycemia हो सकता है. Chronic में oral hydrocortisone you can give it, because once the patient has settled down for chronicity, you can start him on oral tablets. And sick day rules. So whenever the patient is sick, so एक important thing patient को बोलने का, what are the sick day rules? Whenever the patient is undergoing to go under any stress, the patient is not well, when the patient's metabolism is going to increase, that is the time the hormonal what you can say, the demand of hormone is also going to increase, and that time you are going to prescribe the patient with double the dose. So it is called as sick day rule. So it is called as a sick day rule. So what is the sick day rule when it comes to adrenal crisis management? So any patient who is on long term steroid, the patient who is having Addisonian disease, so whenever the patient is going to land up into any disease, whenever the patient is land up into any physical stress, or any patient is going to undergo any surgery, that is the time when you are going to double the doses of the steroid. So patient को बता के रखने का while you are going to discharge the patient, that whenever you are going to have any type of disease, when any type of illness, that is the time you are going to double the doses. So that is called as a sick day rule whenever it comes to your adrenal crisis management. Bilateral adrenalectomy patient. So whenever you are going to do a bilateral adrenalectomy, lifelong steroid dependence रहने वाला है, so patient should always carry an emergency steroid card. तो patient के pocket में रखो कि whenever the patient is going to collapse, you are going to see that card and अरे इसको तो steroid dependency है, इसको डॉक्टर को बुलाओ and give him steroid. So it is very much important for you to know. So this is the Addisonian features. क्या क्या दिखेंगे? तो स्किन में hyperpigmentation दिखेगा, क्यों? क्योंकि ACTH is going to be high. So primary अगर it is going to be an adrenal gland failure, तो ही ACTH बढ़ेगा. तो ACTH बढ़ेगा तो उसमें क्या होगा? There is going to be hyperpigmentation. बट अगर ACTH नहीं बढ़ने वाला है पेशेंट में, तो नेचुरली अगर पिट्यूटरी कॉज है, पिट्यूटरी वी हैव सीन व्हाट इज कॉल्ड एज अ शीहान सिंड्रोम. सो शीहान सिंड्रोम में क्या होता है? आफ्टर पोस्टपार्टम पिट्यूटरी के ग्लैंड के वेसल्स डायलेट होते हैं, अचानक से ब्लड सप्लाई कट ऑफ होता है, एंड दैट इज द रीजन व्हाई पेशेंट लैंड्स अप इनटू अ पिट्यूटरी फेलियर. इट सीमेंट सिंड्रोम और शीहान सिंड्रोम. सो व्हेनेवर अ पेशेंट इज गोइंग टू हैव अ पिट्यूटरी फेलियर, देन दैट इज द टाइम व्हेन ACTH इज गोइंग टू ड्रॉप डाउन एंड हार्मोन्स आर गोइंग टू ड्रॉप डाउन. उस टाइम पे हाइपरपिगमेंटेशन नहीं दिखेगा. लो ब्लड प्रेशर, वीकनेस एंड वेट लॉस. एड्रेनल ग्लैंड्स डू नॉट प्रोड्यूस सफिशिएंट हार्मोन्स, एंड व्हाट इज दैट क्राइसिस? द पेशेंट माइट हैव फीवर, syncope, convulsions, hypoglycemia, hyponatremia, and severe vomiting, because no steroid in the body, the electrolytes and the proper metabolism and homeostasis is not there. The patient might have nausea, vomiting, constipation, typical prodromal symptoms, and skin में patient को vitiligo दिखेगा. Because ACTH is also important for pigmentation, whenever the patient is going to have lack of ACTH, there might be problem of vitiligo in the patient. That is an acquired vitiligo. So it is important for you to know. So now preoperative steroid cover is always important. Whenever a patient is in Addisonian crisis, 100 mg hydrocortisone at the time of induction and at the time of infusion is very much important. So these are the rules which you should know. So whenever you are going to operate this patient, always remember that 100 mg hydrocortisone at the time of induction is the gold standard, and it is going to prevent the patient going into the Addisonian crisis again. Hopefully it is clear. So now we are coming to a tumor which we have already seen in the pediatric surgery module, but here we are going to go into a bit of details. That is a neuroblastoma. We saw that the most common abdominal malignancy in the child in the abdomen is going to be a nephroblastoma, which is a Wilms tumor. उसमें हम लोगों ने दो क्राइटेरिया देखे थे पेशेंट को, अमेरिकन क्राइटेरिया या फिर यूरोपियन क्राइटेरिया. सो इन अमेरिकन क्राइटेरिया they used to give chemotherapy first, downstage the tumor and then take for the surgery. Europeans used to upfront take up for the surgery, and based on the histopathological features, you were deciding that whether the patient is going to require any further chemotherapy or not. Here it is always going to be neuroblastoma. Neuroblastoma is called as a clinical angina. सर क्लिनिकल एंजाइमा का मतलब क्या है? सो अ क्लिनिकल एंजाइमा का मतलब ऐसे होता है कि इट हैज अ वेरी हाईली व्हाट यू कैन से इट हैज अ हाईली वेरिएबल बिहेवियर. So what do you mean by clinical angina? It is going to have a very highly variable behavior. मतलब क्या? तो कुछ पेशेंट्स में ये ट्यूमर अचानक से बढ़ेगा and the next within an instance, within a week or so, the tumor is going to totally regress. So it is a clinical angina. So it might have a spontaneous regression to aggressive metastatic disease within a week's time. तो ट्यूमर का समझता ही नहीं है एग्जैक्टली क्या प्रॉब्लम है. सो दैट इज कॉल्ड एज अ क्लिनिकल एंजाइमा एंड इट इज नथिंग बट अ नेफ्रोब्लास्टोमा इन अ चाइल्ड. सो व्हेनेवर अ क्वेश्चन कम्स दैट व्हाट इज अ क्लिनिकल एंजाइमा, व्हिच ट्यूमर will present as clinical angina, it is going to be a nephroblastoma. I hope it is clear. The most common extracranial solid tumor malignancy in the children, so it is going to be a most common extracranial solid tumor malignancy arising from the neural crest cells and from the sympathetic chain. So we have seen that kidney ka most common tumor is going to be your nephroblastoma. The another important malignancy which is going to be most common extracranial malignancy, it is going to be your nephroblastoma. Median age is around 2 years when the child is going to present, and it is always going to present with a metastatic disease, क्योंकि जो बचपन में ट्यूमर रहने वाला है, it is going to regress on its own. जो ट्यूमर बढ़ेगा, it is going to present with metastasis. Abdominal mass, periorbital ecchymosis with raccoon eyes. We had seen that photo of a baby with raccoon eyes. So that raccoon eyes is not because of trauma. That raccoon eyes, bilateral raccoon eyes, it is because of hyperpigmentation and subperiosteal bleeding, and it might also precipitate with bone pain, hypertension and Horner syndrome. Very much important for you to know. What is this opistoclonus myoclonus? So this is called as a dancing eyes and dancing feet syndrome. It is a paradoxical syndrome. It is an autonomic, autoimmune condition wherein the antibodies which are going to be formed are going to be attacking the own nerve cells. So वो nerve cells होने के बाद में patient को dancing eyes and dancing feet होने वाला है. So this is going to be a typical feature. So a patient with a nephroblastoma is going to have what is called as an opistoclonus myoclonus syndrome, where the patient is going to have dancing eyes and dancing feet. But whenever this paraneoplastic syndrome is going to be present in the child, it is paradoxically going to be associated with better prognosis. So mind you, it is an opistoclonus myoclonus syndrome with dancing eyes and dancing feet. It is going to have a good prognosis. So whenever an MCQ is going to come to you, this is going to be the answer, that it is going to have a good prognosis when the child is going to have this syndrome of opistoclonus and myoclonus. Compression causes, it can cause lymphatic obstruction, pain and spinal cord compression. Tumor markers, so urinary catecholamines are very much important here. We have already seen that क्या करना है diagnosis के लिए, any neuroendocrine tumor first is the biochemical diagnosis, and then you can also go for what is called as a neuron specific enolase or ferritin. So these are all the biochemical markers of the tumor. What is going to be the staging and prognosis? So there are going to be 3 age groups. There are going to be the 3 age groups. Sir age group कैसे divide करोगे? Based on the MYC gene mutation. So MYC नाम का जो जीन रहता है, MYC gene mutation के basis पे we are going to divide the stages into 3 parts: low risk, intermediate risk, moderate risk. So low risk is when there is going to be a favorable histology and no gene amplification, so it is going to be a good prognosis. Intermediate risk मतलब क्या रहता है कि MYC gene amplification नहीं है, it is also going to be a localized or a regional disease. So whenever the disease is going to have the same tumor association, मतलब क्या, तो MYC gene mutation उसमें नहीं है. It is, if it is localized to the adrenal glands or if it is localized to the abdomen, it is considered to be a good prognosis. Low risk. अगर वो लोकली स्प्रेड हो गया है, एब्डोमेन के एब्डोमेन में स्प्रेड हुआ है, तो इट इज एन इंटरमीडिएट रिस्क, बट अभी तक MYC जीन म्यूटेशन आया नहीं है. बट व्हेन इट इज गोइंग टू बी हाई रिस्क, इट इज गोइंग टू बी MYC जीन एम्प्लीफिकेशन. सो एनी MYC जीन एम्प्लीफिकेशन, इट इज गोइंग टू बी अ मेटास्टेटिक डिसीज एट द टाइम ऑफ प्रेजेंटेशन, एंड इट इज गोइंग टू हैव एन अनफेवरेबल हिस्टोलॉजी. सो वेरी मच इंपॉर्टेंट फॉर यू टू नो. So what we saw, that MYC gene is the single most gene which is going to be telling you about the prognosis of the patient. So MYC gene is going to be the single most gene which is going to tell you about the prognosis. Low risk, intermediate risk and high risk. Low risk and intermediate risk में MYC is absent, but it is only the difference of local versus the regional disease. And when it is going to come to your high risk lesion, there is going to be an MYC gene amplification, and it is going to be associated with always going to be associated with metastasis. So very much important for you to study the prognosis of your nephroblastoma. What is the management? So we already saw that MIBG scan is important because any neuroendocrine tumors, MIBG scan is important. Low to intermediate risk, surgery followed by chemotherapy. And whenever it is going to be high risk, first you are going to go for chemotherapy, then surgery, and then again high dose of chemotherapy. So what is important for you to know? If the gene amplification है patient में, तो इसका मतलब पहले जीन को शांत करो, फिर ऑपरेट करो. तो जीन को शांत करने के लिए पहले कीमोथेरेपी देने का, and then you are going to go for your surgical therapy. And when it is going to be low to intermediate risk, you are going to first go for surgery and then go for chemotherapy. So Wilms tumor में भी हमने 2 प्रोटोकॉल देखे थे. इधर it is going to be based on the severity. So low risk, intermediate risk and high risk. MYC gene amplification is the most powerful prognostic factor, and it is only present in 25% of the tumors. So 1/4 of the child, so 4 में से 1 child को ये gene amplification रहेगा, and then that child is going to land up into what is called as a high grade disorder, or it is going to have the high grade tumor. So very important for you to know, and these are the things which are very much important. Typical MCQ points which are important, that always remember that this is the most common extracranial malignancy in the child. It is also associated with a clinical angina, and the third important thing is going to be your opistoclonus myoclonus syndrome, where the child is going to have dancing eyes and dancing feet, and it is going to be paradoxically associated with better prognosis. I hope it is very much clear. So if it is clear, then we are going to move ahead. Then we are going to move ahead to the next chapter, which is going to be our abdominal neuroendocrine tumors. So abdominal neuroendocrine tumors अगर देखोगे तो neuroendocrine tumor basically can be seen anywhere. It can be seen in the skin, it can be seen in the brain, it can be seen in your lungs, it can be seen in the neck. Neck में कौन सा neuroendocrine tumor देखा था? We had seen a carotid body tumor, which was a neuroendocrine tumor. Can be present anywhere in the body. Abdomen में क्या मजा है? Abdomen is a Pandora's box. So exactly you don't know where the tumor is. So in abdomen, localization is very much important. So firstly, we are going to see what is a neuroendocrine tumor. We had already seen what do you mean by neuroendocrine tumor. It is when the patient has going to be a neuronal stimulation which is going to lead to certain enzymes in the blood. So that is called as a neuroendocrine tumor. So they are classified into 3 grades. So what are the 3 classifications? So grade 1, which is well differentiated, grade 2 is going to be well differentiated, but the problem here is the Ki67 is going to be high. So we know that the Ki67 is the mitosis index. So इसमें mitosis index are going to be high, and this is going to be the single most important prognostic parameter. So how is the mitosis going to be? Is going to be told by your Ki67 index. So high Ki67 index मतलब patient का prognosis is going to be bad. Sir Ki67 और कहाँ मिलने वाला है? Ki67 we are going to meet when we are going to talk about the breast carcinoma as well. And grade 3 is poorly differentiated, wherein the Ki67 is very much high, more than 20 mitosis per high power field. Ki67 more than 20, and it is an aggressive tumor. It is also turned out to be a neuroendocrine carcinoma. So we have seen what are the basic categorizations. So what WHO is going to tell you about how to classify the tumor, grade 1, grade 2 and grade 3. उसके basis पे treatment अलग अलग हो सकती है, but this is very much important for you to know because it is going to tell you about the prognosis of the patient. Now we are going to talk about some very much important factors which are generic for all neuroendocrine tumors. So neuroendocrine tumors are going to express what are called as a somatostatin receptors, and these receptors are nothing but SSTR. So somatostatin transmembrane receptor. So somatostatin transmembrane receptor ये सब neuroendocrine tumors में रहने वाले हैं, and that is the reason why this patient is going to have वो somatostatin का हम लोग analog दे सकते हैं, which is an octreotide wherein the tumor can stop functioning, and that is the basis where the gallium dotatate comes into picture, because gallium dotatate is going to use the same receptor to enter into the cell. So what is the basis of gallium dotatate? It is going to enter the cell from the same receptors which are going to be abundantly present when you are talking about the neuroendocrine tumors. So octreotide and lanreotide analogs are going to reduce the hormonal secretions, because these receptors are going to have because these tumors are going to have these somatostatin transmembrane receptors. You can use what are called as octreotide and lanreotide when you are treating the patient for palliative care. So I hope it is clear. Gallium dotatate scan is always superior to CT alone because it is going to detect the occult metastasis. So जैसे हमने thyroid में देखा, तो thyroid में CT scan या फिर PET scan का ज़्यादा कोई importance नहीं था. The only importance in thyroid was when we talked about the radioiodine scan. तो वैसे importance इधर है कि whenever you are talking about the gallium dotatate scan, it is going to be superior because ये SSTR receptors are going to take up the gallium dotatate reagent. And peptide receptor radionucleotide therapy, तो अभी नया nuclear therapy आ रहा है. So there is no role for surgery right now. They are trying to say that it is approved for advanced SSTR plus NET. So this is called as a NETTER-1 trial. So what is the NETTER-1 trial? So whenever you are talking about any neuroendocrine tumors, the NETTER-1 trial is stating that there is a new therapy which is called as a peptide receptor radionucleotide therapy, and here you can give what is called as dotatate, what you can say, the dotatate reagent can be injected and it is going to go and kill the cell. So very much important, it is now getting approved for high risk malignancy features, which is going to help you to downstage the tumor. So concluding that, then we are going to talk about the neuroendocrine tumors of the different organs of your abdomen. तो abdomen में सबसे पहला organ कौन सा आएगा? तो my favorite organ, which is going to be the pancreas. तो पैनक्रियाज मतलब इंपॉर्टेंट चीज एक हमें सामने आया कि दैट इज गोइंग टू बी द इंसुलिन. सो द मोस्ट इंपॉर्टेंट ट्यूमर एंड मोस्ट कॉमन एनकाउंटर मैलिग्नेंसी, द न्यूरोएंडोक्राइन ट्यूमर इन द पैनक्रियाज इज गोइंग टू बी योर इंसुलिनोमा. सो इंसुलिनोमा इज द मोस्ट कॉमन ट्यूमर विच इज एनकाउंटर्ड इन द पैनक्रियाज, विच इज गोइंग टू बी अ न्यूरोएंडोक्राइन ट्यूमर. सो मोस्ट कॉमन फंक्शनल पैनक्रियाटिक neuroendocrine tumor. So it is also called as a peanut. So what is peanut? It is not a peanut. It is nothing to eat. It is a peanut. So what is a peanut? So it is a pancreatic neuroendocrine tumor, and which is the most common pancreatic neuroendocrine tumor. It is going to be your pancreatic insulinoma. Insulinoma. अब भी हम लोगों ने एक बात किया कि what thing did you tell that all the neuroendocrine tumors have what is called as this SSTR, so somatostatin transmembrane receptor, तो ये इंसुलिनोमा में नहीं रहता है. So the first exception to this rule, this generalized rule that somatostatin receptor importance, it is going to be there in the pancreas, that there is not going to be any somatostatin receptor in the pancreatic insulinoma, and that is the reason our investigation is going to change. बाकी सबको generically तुम लिख सकते हो कि you can do a DOTATATE scan, it is going to tell you about the neuroendocrine cells, but here in insulinoma, because of the absence of this receptor, you are not able to diagnose the tumor based on the gallium DOTATATE scan. So just to go, we have seen कि कहाँ हो सकता है, हेड नेक में हो सकता है, we saw that carotid body में रह सकता है, थाइमस एंड थायराइड में रह सकता है. थायराइड में हमने पीनेट देखा था, विच इज अ मेडुलरी कार्सिनोमा ऑफ थायराइड. इट इज ऑल्सो टाइप ऑफ पीनेट. ब्रेस्ट में रह सकता है, लंग्स में रह सकता है. लंग में इट इज कॉल्ड एज अ कार्सिनॉइड ट्यूमर ऑफ द लंग्स, और इट माइट बी एसोसिएटेड विद स्मॉल सेल कार्सिनोमा. सो स्मॉल सेल कार्सिनोमा ऑफ लंग कैन बी एसोसिएटेड विद व्हाट इज कॉल्ड एज अ पैंक्रियाटिक न्यूरोएंडोक्राइन ओरिजिन. जीआईटी एंड पैंक्रियाज अभी हम देख रहे हैं. जेनेटो यूरिनरी ट्रैक में वेरी रेयर चांसेस, एंड स्किन में भी रह सकता है, विच प्रेजेंट्स एट द रेडियो वायलेट प्लग. सो दे हैव ऑलरेडी सीन दैट जीआईटी में 3 डॉट दिए, मतलब जीआईटी में मोस्ट कॉमन है, लंग्स में सेकंड मोस्ट कॉमन है, बाकी सब बहुत ही रेयर है. So we are going to predominantly talk about the GIT and pancreas right now. Lung में जब हम thorax पढ़ेंगे तो we are going to talk about the lung peanuts in the thorax module. So what are the key feature of insulinoma? So normally remember that insulinoma is mostly benign tumor. So few important things that it is going to be a benign tumor, and when you are considering it benign, always remember that usually less than 2 cm in size, and it is considerably going to have a benign pathology. So less than 2 cm is going to be a benign behavior. It is going to be solitary. Solitary मतलब क्या, एक ही जगह पे मोस्टली प्रेजेंट रहने वाला है. It might not be present scattered multiple places. Why? Because it is important to know, because we don't have a localization study like DOTATATE scan. So DOTATATE scan जहाँ पे बॉडी में कहाँ पे भी न्यूरोएंडोक्राइन सेल से बताएगा, बट इंसुलिनोमा बता सकता है नहीं. सो गैलियम DOTATATE स्कैन का एक ही ड्रॉबैक है, दैट इट कैन नॉट टेल अबाउट द इंसुलिनोमास इन द बॉडी. एंड वी हैव सीन दैट पैंक्रियाटिक न्यूरोएंडोक्राइन ट्यूमर्स, द पैंक्रियाटिक ट्यूमर्स वेर अ पार्ट ऑफ MEN1 syndrome, where there were 3 P's in the men, the pituitary, if you remember, the pituitary, the parathyroid and the pancreas. So ये 3 चीजें हमने MEN1 syndrome में देखी थी. So that is important. And MEN1 syndrome में insulinomas need a distal pancreatectomy. So I'm going to tell you how to manage this patient. So there are few facts about it. An equal sex distribution and most commonly seen in the body and tail of pancreas. So ये सब चीजें मुझे पता है. I hope this is very much clear. So now we are going to talk about a Whipple's triad. So Whipple's triad एकदम बेसिक है. इसका मतलब क्या रहता है कि अगर मैंने आपको एक झापड़ मारा है, फिर आपने मुझे झापड़ मारा, आई एम नॉट हिटिंग यू, यू आर हिटिंग मी, तो व्हाट डज दिस से कि अरे इसने आनंद को झापड़ मारा. ओके, दैट इज द फर्स्ट रूल. ओके, आनंद ने इसने आनंद को झापड़ मारा, है पहला रूल हो गया. दूसरा रूल क्या है कि झापड़ मारने के बाद में आनंद को गाल पे लग गया. ऑब्वियसली मारेगा तो लगेगा ही, तो दैट इज द सेकंड रूल विच इज देयर. एंड उसको झापड़ मारने के बाद में आनंद का दूसरा गाल जो था वो एकदम नॉर्मल था, तो ऑब्वियसली लेफ्ट गाल पे झापड़ मारा तो राइट गाल नॉर्मली रहने वाला है. तो यही विपल्स ट्रायड है. एक ही चीज 3 बार रिपीट की है इन डिफरेंट एंगल्स. सो सिम्टम्स ऑफ हाइपोग्लाइसीमिया ड्यूरिंग फास्टिंग और एक्सरसाइज. तो पेशेंट जब फास्टिंग में रहेगा तो उसको हाइपोग्लाइसीमिया होगा. ऑब्वियसली जब उसको हाइपोग्लाइसीमिया रहेगा तो नेचुरली पेशेंट को उसका ब्लड ग्लूकोज लेवल इज गोइंग टू बी लो, क्योंकि उसको हाइपोग्लाइसीमिया है. एंड ऑब्वियसली अगर उसको हाइपोग्लाइसीमिया है, उसका ग्लूकोज कम है, तो उसको ग्लूकोज देने के बाद में और अच्छा लगने वाला है. सो वेरी मच सिंपल. मैंने क्या बोला, किसी ने आनंद सर को झापड़ मारा, झापड़ मारने के बाद में आनंद को लग गया, तो पहला फैक्ट इज आनंद को झापड़ मारा. दूसरा फैक्ट क्या है कि ऑब्वियसली उसको जहां पे मारा उधर लगने वाला है. और तीसरा फैक्ट क्या है कि ऑब्वियसली जिस गाल पे झापड़ नहीं मारा वो गाल नॉर्मल है. तो वही सेम चीज विपल्स ने पैंक्रियाटिक इंसुलिनोमा में बताया, दैट द सिम्टम्स आर गोइंग टू बी सीन ड्यूरिंग द फास्टिंग. दैट इज द फर्स्ट रूल. ऑब्वियसली व्हेन देयर इज गोइंग टू बी अ हाइपोग्लाइसीमिया, देयर इज गोइंग टू बी लो ब्लड शुगर लेवल. सो जब सिम्टम्स आएंगे और शुगर देखोगे तो ऑब्वियसली द शुगर इज गोइंग टू बी लो. एंड थर्ड थिंग, उसको हाइपोग्लाइसीमिया है इसलिए उसको सिम्टम्स है, तो व्हेनेवर यू आर गोइंग टू गिव ग्लूकोज, नेचुरली द सिम्टम्स आर गोइंग टू बी रिड्यूस्ड. So very simple analogy, and you should know it. And this is going to be the diagnostic criteria, biochemical diagnostic criteria. This is one of the criteria for diagnosing the insulinoma. So it is going to have elevated fasting insulin levels plus C-peptide levels, and that is what is going to differentiate from the exogenous insulin. तो let's consider कोई पेशेंट बाहर से इंसुलिन ले रहा है, तो उसको कैसे डिफरेंशिएट करने का कि इज दिस इंसुलिन. सो इफ यू आर गोइंग टू चेक द इंसुलिन लेवल्स इन द ब्लड, दे आर गोइंग टू बी हाई, बिकॉज इंसुलिनोमा में इंसुलिन इज गोइंग टू बी हाई. सो व्हेन यू आर गोइंग टू चेक द ब्लड फॉर इंसुलिन लेवल्स, यू विल फाइंड आउट दैट अरे इसके तो इंसुलिन लेवल्स हाई है, बट इज इट एक्सोजेनस इंसुलिन और एन एंडोजेनस इंसुलिन. तो उसके लिए वी नो दैट द इंसुलिन इज फर्स्ट फॉर्म्ड इन द लॉन्ग चेन, and then the insulin is going to be cut at 2 places, and this dipeptide chain is going to be secreted in the blood, and ये जो एक्सक्रीट होने वाला पार्ट है उसको हम बोलेंगे सी पेप्टाइड, विच इज गोइंग टू बी ओनली फॉर्म्ड इन द ह्यूमन बॉडी. सो सी पेप्टाइड अगर बढ़ रहा है तो इसका मतलब ये है कि द इंसुलिन इज गेटिंग फॉर्म्ड इनसाइड द ह्यूमन बॉडी. सो क्या करना है, तो पेशेंट को डायग्नोस्टिक टेस्ट इज गोइंग टू बी सुपरवाइज 72 आवर्स फास्टिंग. इट इज द गोल्ड स्टैंडर्ड टेस्ट. तो पेशेंट को पर्पजली हम लोग हाइपोग्लाइसीमिया करने वाले हैं. एंड 98% इंसुलिनोमास आर डायग्नोज्ड बाय जस्ट मैन्योर, बट घर पे भेज के ये टेस्ट कर नहीं सकते, पेशेंट को एडमिट करना पड़ रहा है. एंड ऑल्सो देयर इज अ थिंग कॉल्ड एज पोस्ट एक्सरसाइज हाइपोग्लाइसीमिया. इट एंड if the patient is having post exercise hypoglycemia, the patient might have risk of sudden coma or death during the exercise. Very much important. So how are you going to diagnose and localize? So low blood sugar, high insulin levels, obviously high C-peptide level because the insulin is getting secreted in the blood from the human body. Cross-sectional imaging is often negative because अगर तुम देखोगे तो ये इसमें वो रिसेप्टर ही नहीं है, सोमैटोस्टैटिन ट्रांसमेम्ब्रेन रिसेप्टर ही नहीं है ये सेल में, तो ऑब्वियसली गैलियम डोटाटेट उसको पिकअप नहीं करेंगे. तो कौन सा इन्वेस्टिगेशन है? तो हियर द इन्वेस्टिगेशन ऑफ चॉइस इज ऑलवेज गोइंग टू बी एन एंडोस्कोपिक अल्ट्रासाउंड. तो एंडोस्कोपिक अल्ट्रासाउंड में क्या होगा? जब यू आर गोइंग टू प्लेस द गैस्ट्रोस्कोप नियर द डियोडेनम D1 D2 D3, तो तब पैनक्रियास का पूरा विजुअलाइजेशन हमें मिलेगा एंड उसमें हमें वो ट्यूमर दिखने वाला है. यू कैन ऑल्सो टेक द FNAC ड्यूरिंग दैट टाइम इफ यू वांट टू गो फॉर डायग्नोसिस. CT एंड MRI इज द फर्स्ट लाइन इमेजिंग एंड आर्टेरियल फेज एनहांसमेंट माइट बी सीन. सो मैंने देखा कि देयर इज नो रोल ऑफ डूइंग अ गैलियम डोटाटेट स्कैन, बट क्या कर सकते हो? MRI या फिर MRCP ऑफ पैनक्रियास करो सो दैट यू कैन सी द पैनक्रियाटिक पैरेन्काइमा. गैलियम डोटाटेट इट इज यूजफुल इफ इट इज EUS is negative because some insulinomas have low level of SSTR expressions, so that is the reason why false negative rates are highly possible. Because insulinoma में अगर US में भी नहीं दिख रहा है तो फिर भी you can give it a try, but the receptors are very much low, तो नॉर्मली वो पिकअप नहीं करने वाले हैं. एंड इंट्रा ऑपरेटिव पाल्पेशन इज ऑल्सो इंपॉर्टेंट. मोस्ट ऑफ द टाइम्स क्या होता है, वो लीजन सोनोग्राफी में दिख जाता है, बट व्हेन यू आर डूइंग द सर्जरी यू माइट नॉट सी अ ट्यूमर वेरी वेल. सो दैट टाइम यू हैव टू व्हाट इज इंपॉर्टेंट दैट यू व्हेन यू आर नॉट सीइंग द ट्यूमर यू कैन आइदर गो फॉर इंट्रा ऑपरेटिव अल्ट्रासाउंड. इट इज गोइंग टू डिटेक्ट द 95 to 99% ऑफ द लीजन. सो वेरी मच इंपॉर्टेंट फॉर यू टू नो. सर मैनेजमेंट क्या है? तो ऑलवेज रिमेंबर व्हेनेवर इट इज अ स्पोरेडिक मैनेजमेंट, व्हेनेवर स्पोरेडिक मैनेजमेंट मतलब क्या? तो पेशेंट को कोई भी सिंड्रोम नहीं है. So non-syndromic sporadic management, you are going to go for enucleation if it is going to be away from the duct. So always remember when that insulinoma is going to be away from the duct, you are going to go for enucleation if it is going to be distant from the duct. So let's consider this is your pancreas, this is your pancreas, this is your pancreas, this is the pancreatic duct. So if the tumor is sporadic, मैंने क्या बोला? Sporadic मतलब there is no genetic mutation, and if the tumor is having 3 centimeter distance, the 3 centimeter distance from the 3 mm distance, so your distance is 3 mm, so that is the time you can safely go for enucleation of the tumor. So you can go for safe enucleation of the tumor. But अगर ये tumor placed है near the duct, if it is placed near the duct, then that is the time you cannot compromise on the duct. You have to go for what is called as a distal pancreatectomy. So distal pancreatectomy कब करोगे? अगर ये tumor duct के बहुत नजदीक है तो you will go for a distal pancreatectomy. If it is away from the duct you will go for a enucleation. पर अगर ये syndromic associated है तो syndromic association मतलब there is high chance of recurrence. हमने already देखा कि tumors are most commonly seen in the body and tail of the pancreas. क्यों? क्योंकि islet cells are more commonly seen in the body and tail of pancreas. So whenever the patient is having syndrome there are high chances of recurrence. So any syndromic patient, अगर MEN syndrome diagnosed patient है तो any syndromic patient the management is always and always going to be a distal pancreatectomy whenever it is associated with syndrome. So syndromic association है तो always and always you are going to go for a distal pancreatectomy, no compromise. Very much important fact. अगर मेन वन है तो मल्टीपल लीजन्स हो सकते हैं. डिस्टल पैनक्रिएटेक्टमी इज वेरी मच इंपॉर्टेंट. एंड इंट्राऑपरेटिव अल्ट्रासाउंड करने का कि हेड नेक में कोई लीजन छूट नहीं रहा है, नहीं तो क्या करोगे? इधर पैनक्रियास पूरा निकाल दोगे और हेड का एक लीजन मिस आउट हो जाएगा. मैलिग्नेंट इंसुलिनोमा है तो इट इज गोइंग टू हैव अ वेरी ग्रेव प्रोग्नोसिस. सो यू हैव टू गो फॉर अ डीबल्किंग सर्जरी. सर व्हाट इज दिस ड्रग? सिवरोलिमस और इवरोलिमस. इट इज एन mTOR इनहिबिटर. सो mTOR इनहिबिटर्स हम वापस देखने वाले हैं व्हेन वी आर गोइंग टू टॉक अबाउट द इम्यूनोथेरेपी एंड आल्सो वी आर गोइंग टू टॉक अबाउट द ट्रांसप्लांट. दीज आर इम्यूनोसप्रेसिव ड्रग्स एंड mTOR इनहिबिटर्स कैन be used, which is everolimus and streptozocin based chemotherapy हम ये पेशेंट को दे सकते हैं. अनरिसेक्टेबल पेशेंट है तो व्हेन द पेशेंट इज अनरिसेक्टेबल मतलब पेशेंट को सर्जरी अगर पैलेट ही नहीं होने वाला है, पेशेंट इज नॉट एबल टू टॉलरेट एनी टाइप ऑफ सर्जरी, पेशेंट को तुम कुछ भी नहीं कर सकते हो, तो क्या करना है? पैलिएटिव देना है. तो पैलिएटिव मतलब क्या? पेशेंट को बोलोगे क्या कि एक ग्लूकोज की बोतल मुंह में लगा के घूमो हर जगह पे, तो इट इज नॉट पॉसिबल. तो इंसुलिन सिक्रीशन सप्रेस करने के लिए हमारे पास में एक ड्रग है, दैट इज द डायाजॉक्साइड. तो पेशेंट को डायाजॉक्साइड देने के बाद में इंसुलिन सिक्रीशन कम होगा एंड यू कैन ऑन द कॉन्ट्ररी टेल द पेशेंट टू हैव फ्रीक्वेंट कार्बोहाइड्रेट मील्स. एंड octreotide might be there but it may worsen the hypoglycemia sometimes because ऑक्ट्रियोटाइड दोगे तो इवन इंसुलिन जो मतलब जो प्रॉपर गट का मोटिलिटी भी मेंटेन नहीं रहेगा, प्रॉपर ब्लड सप्लाई भी नहीं रहेगा, तो देयर माइट बी हैप्पैजार्ड इनटेक ऑफ द न्यूट्रिएंट्स इनसाइड द बॉडी एंड पेशेंट को मोस्ट ऑफ द टाइम्स खाना खाने के बाद भी हाइपोग्लाइसेमिया होगा. सो ऑक्ट्रियोटाइड ऑलवेज यूज वाइजली इन दीस पेशेंट्स, बट व्हाट यू कैन यूज इज यू कैन गिव व्हाट इज द ड्रग व्हिच इज कॉल्ड एज अ डायाजॉक्साइड. सो डायाजॉक्साइड कैन बी गिवन टू दिस पेशेंट. सो डायाजॉक्साइड माइट हेल्प द पेशेंट. सो आई होप इट इज वेरी मच क्लियर. अगर ये क्लियर है तो नाउ वी आर गोइंग टू गो टू द सेकंड डिसऑर्डर एंड देन वी आर गोइंग टू कंपेयर बोथ ऑफ देम, बिकॉज कंपेयर करोगे तो ज्यादा अच्छे से ध्यान में रहेगा. सो नाउ वी आर गोइंग टू टॉक अबाउट व्हाट इज कॉल्ड एज अ गैस्ट्रिनोमा. सो गैस्ट्रिनोमा इज अ गैस्ट्रिन सिक्रीटिंग ट्यूमर. गैस्ट्रिन मतलब क्या, तो वी नो दैट द स्टमक has the cells which are called as the parietal cells which are going to secrete the acid. तो उसको stimulate करने के लिए there are going to be H receptors, the H plus receptors are going to be there and the gastrin receptor is going to be there. So gastrin is going to increase the acid suppression. तो gastrin क्यों बढ़ेगा रे शरीर में, तो any thing which is associated with hypergastrinemia it is termed to be what is called as a any condition which is going to be associated with more gastrin in the blood, it is called as hypergastrinemia. तो क्यों होगा, तो it might be a tumor. So it might be a tumor. So there might be massive HCl secretion in the body with severe peptic ulcer disease. So क्या cause हो सकते हैं, दो causes क्या हो सकते हैं. So why will the gastrin be high? So gastrin क्यों बढ़ेगा बॉडी में, तो एक काम अगर one problem is that the patient is having problem with the parietal cells. क्योंकि पेशेंट को एसिड कम हो रहा है, लेस एसिड सिक्रीशन, एंड दैट इज द रीजन व्हाई देयर इज गोइंग टू बी कंपेंसेटरी मोर गैस्ट्रिन लेवल्स. तो ये कौन सी कंडीशंस है, तो एक कंडीशन तो आइट्रोजेनिक है जो हम लोग भी कॉज कर सकते हैं, दैट इज पीपीआई अब्यूज. सो पीपीआई अब्यूज के वजह से पेशेंट को हाइपरगैस्ट्रिनेमिया हो सकता है. सर और क्या हो सकता है, वी हैव ऑलरेडी सीन व्हाट इज कॉल्ड एज एन ऑटो इम्यून गैस्ट्राइटिस. सो ऑटो इम्यून गैस्ट्राइटिस अगर आपको पता है, पर्निशियस एनीमिया वेयर द पैराइटल सेल्स आर नॉट गोइंग टू सीक्रेट व्हाट इज कॉल्ड एज एन इंट्रिंसिक फैक्टर एंड ऑलवेज देयर गोइंग टू बी अक्लोराइड्रिया. सो अक्लोराइड्रिया may be secondary to pernicious anemia. So pernicious anemia अगर पेशेंट को है तो भी उसका पैराइटल सेल काम नहीं कर रहा है, तो इन दोनों कंडीशन में भी मुझे क्या दिखेंगे, आई कैन सी मोर गैस्ट्रिन. एंड और गैस्ट्रिन मुझे कहाँ दिखेगा, तो ऑब्वियसली जो गैस्ट्रिन सिक्रीटिंग सेल्स है उसका ट्यूमर है, तो एंड उसको ही मैंने क्या बोला, उसको मैंने बोला गैस्ट्रिनोमा. So gastrinoma is nothing but a tumor which is going to be of the gastrin cells which is going to secrete gastrin in the blood which is going to cause either. So इस कंडीशन में क्या रहेगा, इस कंडीशन में पेशेंट के बॉडी का एसिड लेवल बढ़ेगा, बॉडी का एसिड एज इन द स्टमक का एसिड लेवल बढ़ेगा. सो ये दो कंडीशन पहले फिट करो कि व्हाई इज द गैस्ट्रिन इंक्रीज. सो गैस्ट्रिन माइट बी इंक्रीज बिकॉज ऑफ टू कॉजेस. सो उसमें मेरे को वही देखना है कि नॉर्मली अगर ये ट्यूमर रहता है तो इट इज लोकेटेड इन द गैस्ट्रिनोमा ट्रायंगल विच इज कॉल्ड एज अ पसाराउस ट्रायंगल. So Passarau triangle अगर मैंने देखा, so this is the Passarau's triangle. So you can see that the junction of the common bile duct with the cystic duct. So this is the junction. Here is going to be D2 with D3 and other is going to be the neck of the pancreas. तो ये तीनों चीजों को तुम join करोगे तो here it is going to be the Passarau's triangle. So it is the junction of common bile duct and cystic duct, second and third part of the duodenum and neck and the body of pancreas. So this diagram has a bit shown it in the wrong way. So ideal triangle would have been like this. So this is the ideal triangle. So this is going to be the ideal triangle. So this is going to be the Passarau's triangle where there is going to be presence of the gastrinoma. तो अगर तुम्हें मिल नहीं रहा है, गैस्ट्रिन लेवल्स हाई है पेशेंट के, एसिडिटी बहुत हो रही है पेशेंट को, सीरम गैस्ट्रिन करोगे तो सीरम गैस्ट्रिन इज हाई, यू आर नॉट एबल टू डायग्नोज द लोकेशन ऑफ द डिसीज, देन यू आर गोइंग टू गो फॉर फोकस्ड अल्ट्रासाउंड ऑफ दिस रीजन और एंडोस्कोपिक अल्ट्रासाउंड ऑफ द लीजन. बट मुझे वो करने का जरूरत नहीं, बिकॉज वी नो दैट सोमैटोस्टैटिन रिसेप्टर आर गोइंग टू कम टू माई हेल्प एंड आई एम गोइंग टू बी एबल टू डू अ gallium DOTATATE scan. So very much important for you to know. So duodenal gastrinomas are small, multiple in the duodenal wall and they have the better prognosis because they are going to be mostly benign. Pancreatic gastrinomas are large with worse prognosis and they are going to have more risk of malignancy. Slow progressing tumors, so sporadic gastrinoma have worse prognosis than MEN1 association. So उधर हमने देखा था pancreas insulinoma में that insulinomas which are insulinomas एक तो benign रहते हैं most of the times, but when they are associated with MEN syndrome they are going to have worse prognosis, hence distal pancreatectomy was indicated. But इस condition में अगर देखोगे तो sporadic gastrinomas have worse prognosis because mostly sporadic gastrinomas are going to occur in the pancreas and pancreas में malignancy rate are going to be high. So no single reliable behavior marker, मतलब ऐसे कुछ भी नहीं हमारे पास में कि जिससे you can tell that if this gastrinoma is going to be a benign or is it going to be a malignant. So कुत्ता कौन सा है, is it a wild dog or is it a pet dog, we are not able to be understand with any type of the parameters. So parathyroidectomy in MEN1, it also reduces the risk of gastric acid secretion because we know that PTH is going to stimulate the gastrin and also calcium is going to stimulate the acid. So ये सब चीजें, so they have given a thing that whenever you are going to do a parathyroidectomy in MEN1 syndrome, so most of the times doing a parathyroidectomy in the MEN1 syndrome, it is going to potentiate the gastrin effect. So gastrin effect potentiate karega and hence the it can actually what you can say, So it reduces the gastric secretions and the patient might be saved from getting a gastrinoma in the future. So very much important for you to know. So diagnosis कैसे करोगे? Obviously it is going to be BLS. So BLS protocol अगर follow करना है endocrinology में, तो what is the BLS protocol? First is the biochemical marker. So serum gastrin levels more than 1000 picograms. It is an essential diagnosis. उधर मैंने क्या बोला था? Whipple's triad, आनंद सर की झापड़ याद आ गई. अब मैंने क्या बोला? It is going to be a serum gastrin level. So and if the serum gastrin level is still not diagnostic, you can go for what is called as a secretin stimulation test. So when you are going to inject secretin into the blood, it is going to cause paradoxical rise in the gastrin levels. So whenever the gastrin levels are going to rise in basis of secretin, it is going to be positive for it is going to be positive for your gastrinoma. And you can always measure a basal acid output. So whenever the stomach acid output देखोगे, whenever you are going to go for gastric acid output monitoring, more than 15 milliequivalent acid secretion per hour, तो उसके लिए अलग अलग मेथड्स है gastric acid output monitor करने के, 24 hours endoscopy वगैरह वगैरह, तो वो सब चीज़ों में जाने की जरूरत नहीं है. बट gastric acid output अगर तुम मॉनिटर करोगे, तो if more than 15 milliequivalents per hour अगर प्रेजेंट है, तो then there might be a chance that this patient might have hyperacidity and you should rule out the causes. Important, कोई भी पेशेंट को hypergastrinema, gastrinoma लेबल करने से पहले rule out the PPI use, because omeprazole and other are going to rise the gastrin. H pylori might also, because H pylori is going to reduce the stomach gastric acid and उसके वजह से reflux gastrin बढ़ने वाला है, and retain gastric antrum before diagnosis. So always remember that H pylori and your important drugs like PPI should be ruled out whenever you are dealing with the gastrinoma. And imaging में CT and MRI can be done, endoscopic ultrasound can be done near the Passaro's triangle, but gallium DOTATATE scan is the most sensitive. It is going to pick up wherever the lesions are going to be there. And that is also called as a somatostatin receptor scintigraphy. So important for you to know that whenever the gastrin is going to be high, what you can do is you can straight away post the patient for what is called as a gallium DOTATATE scan, and gallium DOTATATE scan is going to pick up the lesion. So here you can see what is a gallium DOTATATE scan. I think I've put it up later, so I'll show you the gallium DOTATATE scan also. So what is gallium DOTATATE scan? I'm going to show it to you later. So very much important. So first, जैसे मैंने बोला कि पेशेंट कोई भी अगर आता है तो BLS, we have done biochemical test, then we went for localization में gallium DOTATATE scan किया, and now you are going to go for stabilization of the patient. Stabilization करने के लिए obviously first acid control करो, acid इतना बढ़ रहा है तो पहले acid control करो. तो ये पेशेंट में जिसमें ट्यूमर के वजह से गैस्ट्रिन बढ़ा हुआ है, again I am trying to say that a patient who is going to have gastrinoma, this is not hypergastrinemia management, this is gastrinoma. पेशेंट को गैस्ट्रिनोमा है, लोकलाइज्ड गैस्ट्रिनोमा है, देन यू आर गोइंग टू स्टार्ट द पेशेंट ऑन हाई डोज पीपीआई. नहीं तो बोलोगे अरे सर पीपीआई की वजह से ही गैस्ट्रिन बढ़ गया और तुम और पीपीआई दे रहे हो. सो अगेन आई एम ट्राइंग टू से दैट ओनली एंड ओनली व्हेन देयर इज गोइंग टू बी अ गैस्ट्रिनोमा, व्हेन देयर इज गोइंग टू बी अ ट्यूमर, देन एंड ओनली देन यू आर गोइंग टू गिव द पेशेंट व्हाट इज कॉल्ड एज अ पीपीआई, व्हिच कैन बी ओमेप्राजोल 60 mg पर डे. नॉर्मली ओमेप्राजोल का टैबलेट 20 mg ओडी देते हैं हम लोग, तो इधर हम ओडी नहीं टीडीएस भी दे सकते हैं. इट इज ड्रामेटिकली गोइंग टू रिड्यूस द कॉम्प्लिकेशंस. सो इट इज द फर्स्ट स्टेप, बिकॉज द पेशेंट माइट हैव मल्टीपल gastric acid, patient might have multiple ulcers, they might perforate and they might cause a deadly complication. So sporadic अगर है तो मैंने वही बोला कि pancreas में अगर देखा insulinoma है तो if it is a sporadic tumor it is a good prognosis, but here the sporadic has the bad prognosis. You are going to go for resection if it is localized. You can go for duodenal exploration and regional lymphadenectomy. So most of the times you can go for an intraoperative ultrasound. जो lesions दिख रहे हैं वो सब part you can resect it off. Men 1 का अगर gastrinoma less than 2 cm है तो you can just observe. If it is more than 2 cm then also you have to resect, because we saw that in Men syndrome there are multiple small gastrinomas present in the duodenum. So Men syndrome में most common location. So there is an MCQ. This is an MCQ pointer. So whenever you are talking about Men syndrome, gastrinomas are going to be present in a very small, let's the MCQ point. So whenever you are going to talk about Men 1 syndrome, the gastrinoma size is going to be very small, which is going to be present typically in the duodenum. But whenever it is going to be present in the pancreas, it is going to have a grave prognosis. So whenever it is in Men syndrome, it is going to have they are going to be small in size and you need not go for resection. So Men syndrome, small duodenal gastrinomas, and you need not resect. But pancreatic neoplasm, any pancreatic gastrinoma is always resected, any sporadic is always resected, any more than 2 cm always resected. And unresectable अगर है तो पेशेंट को अगेन सोमेटोस्टैटिन एंटागोनिस्ट दे दो. तो पेशेंट को अगर तुम ऑक्ट्रोराइड दोगे तो नेचुरली द पेशेंट इज गोइंग टू इंप्रूव. एंड ऑल्सो उसके साथ में पीपीआई देना है, पेशेंट को पीपीआई देना है. एंड दिस इज वेरी मच इंपॉर्टेंट दैट यू आर गोइंग टू गो फॉर इवरोलिमस एंड स्ट्रेप्टोजोसिन बेस्ड कीमोथेरेपी। तो कहीं पे भी अगर लाइफ में स्ट्रेप्टोजोसिन बेस्ड कीमोथेरेपी पड़ा तो इट मींस दैट इट इज अ न्यूरोएंडोक्राइन ट्यूमर। तो स्ट्रेप्टोजोसिन बेस्ड कीमोथेरेपी इट इज वेरी मच इंपॉर्टेंट व्हेन यू आर गोइंग टू गिव इट टू द पेशेंट व्हेन द पेशेंट इज गोइंग टू हैव अ न्यूरोएंडोक्राइन ट्यूमर। I hope it is very much clear. So now before going ahead, we are going to do a comparative chart between the tumors of gastrinoma and insulinoma. So gastrinoma versus insulinoma, let's start. So pancreatic neuroendocrine lesions को तुम पहले डायग्नोस कैसे करोगे? So always you are going to go for first thing is going to be your B, which is going to be a biochemical test. Biochemical test में अगर तुमने देखा तो when you are suspecting an insulinoma, you are going to go for what is called as a Whipple's triad. Whipple's triad मतलब हमने already ये तीन चीजें देखी हुई है. So whenever a Whipple's triad is positive, you can do a hypoglycemic study by admitting the patient inside your ward, or also you can do what is called as a C-peptide study. So ये study अगर हम लोगों ने किया तो ये हमें पता चलेगा कि endogenous insulin is very much high, and then you are going to suspect it as insulinoma. But अगर insulinoma diagnose हो गया biochemically, then there is the time of localization. So localization के लिए BLS, so that is L. So what is for the localization study? There is no role of DOTATATE scan because the somatostatin receptors are absent on the what you can say pancreatic cells or insulinoma cells. So you are going to go for localization study with the endoscopic ultrasound. What did we see? If it is going to be associated with syndromic association, most common location is in the tail and body of pancreas, because we already know that the islet cells are common in tail and body of pancreas. So if it is associated with syndromes like MEN syndrome, you are going to go for pancreatectomy. The distal pancreatectomy or tail pancreatectomy is the investigation of the management of choice. But whenever you are talking about a non-syndromic association, a sporadic tumor, you are going to see that whether it is close to the duct or whether it is away from the duct. So whether if it is going to be away from the duct, here you can put the patient only on enucleation therapy. But if the patient is going to have it near the duct, you are going to go for a pancreatectomy, distal pancreatectomy, very much important. Now again coming to the contrary side, whenever the patient is going to have features like hyperacidity, you are going to check for the fasting serum, what you can say gastrin levels. When you are going to check the gastrin levels, you are also going to augment it with what is called as a secretin study. So secretin study भी हम लोग उसके साथ कर सकते हैं. We know that somatostatin receptors are very well present on the gastrinoma, so you can go for a gallium DOTATATE scan. So localization, so पहले मैंने biochemically analyze किया, then I'm going to go for a localization with the gallium DOTATATE scan. And if the tumor is going to be sporadic, मतलब क्या, तो ये ट्यूमर अगर पेशेंट को नॉन सिंड्रोमिक है तो इट हैज हाई मैलिग्नेंट पोटेंशियल. सो ऑलवेज एंड ऑलवेज any type of sporadic tumor which is a gastrinoma which should resect exactly opposite to the insulinoma. And if it is a syndromic association, we saw that in the syndrome there are multiple small lesions in the duodenum, not in the pancreas. So less than 2 centimeter lesions hai, so you can just observe the patient, and if it is more than 2 centimeter, then again risk of malignancy increases. So you are going to go for excision in this patient. And when you are going to observe the patient, what you are going to do, you are going to give PPI to the patient and you can give octreotide. And as the somatostatin receptors are absent in the insulinoma, there is no role of octreotide. Here what you can give, here you can give what is called as a diazoxide. You can give what is called as diazoxide. अगर octreotide इधर दोगे तो actually hypoglycemia might worsen. So diazoxide is the management when it comes to insulinoma. So I hope it is crystal clear. So now we are going to talk about some non-functional PNETs. So एक तो हो गया कि पेशेंट को कुछ सिम्टम्स है इसलिए पेशेंट अपने पास आया तो हमने उसको डायग्नोस कर दिया. बट द second stuff is going to be that the patient is going to have a routine USG. पैनक्रियास में लीजन आ गया, पैनक्रियास में लीजन आ गया, सीटी कराया, सीटी में बोल रहे कि इट इज नॉट मैलिग्नेंट लीजन. वी आर गोइंग टू टेल यू दैट all the malignancy of the pancreas is going to be diagnosed on the basis of CT scan. But if the CT scan is not going to be conclusive, then you are going to go for a nuclear study. And nuclear study में तो हो गया अरे ये तो PNET है, but this PNET is not actually functioning. The patient is not going to have any symptoms. So normal golden rule क्या है? If it is less than 1 centimeter, go for active surveillance. 1 to 2 centimeter है तो consider resection if symptomatic or MEN syndrome association. So most of the times क्या है? Patient को already MEN syndrome diagnosed है, and the patient is going to come to you with incidental diagnosis of a PNET on the pancreas. तो patient का जो routine workup करा लेते हैं medullary carcinoma के your parathyroid के लिए, pituitary के लिए, तो उसमें patient को pancreatic lesion भी निकला. तो MEN syndrome है, अगर lesion more than 1 centimeter है तो you are going to go for resection. More than 2 centimeter, any PNET should be always amenable for surgical resection. So any PNET, whether it is functioning or non-functioning, more than 2 centimeters, it is resection. If 1 to 2 centimeters non-functioning PNET, you are going to ask the patient if the patient is going to have, if the patient is going to have syndromic manifestations or symptoms. If syndrome hai to resect, and less than 1 centimeter, any PNET is always going to be considered. So non-functional PNET अगर short note आया तो मुझे पता है कि what I am going to write in the short note. I hope it is crystal clear. So now coming down to another type of tumors which are now going to be a stomach tumor or another tumor of the gut, the intestines. These are going to be the carcinoids. So these are also so these are also neuroendocrine tumors. So carcinoid tumors are nothing but these are going to be neuroendocrine tumors of the GI tract. So foregut, midgut and hindgut. अगर उसमें से किसी भी hollow viscous को कुछ भी न्यूरोएंडोक्राइन ट्यूमर हुआ तो उसको कार्सिनॉइड बोलते हैं. जैसे देयर माइट बी अ ब्रोंकियल कार्सिनॉइड, देयर माइट बी अ लंग कार्सिनॉइड बिकॉज इट डेवलप्स फ्रॉम द फोरगट एंड इट इज अ होलो विस्कस. सो इट इज अ होलो विस्कस, ट्रेकिया इज होलो, सो दैट इज गोइंग टू बी अ लंग कार्सिनॉइड. अगर स्टमक में आ गया तो इट इज गोइंग टू बी अ गैस्ट्रिक कार्सिनॉइड. इफ इट इज देयर इन द अपेंडिक्स इट इज गोइंग टू बी अ अपेंडिकुलर कार्सिनॉइड. इफ इट इज गोइंग टू बी इन द स्मॉल bowel it is going to be a small bowel carcinoid. So I'm going to tell you a very interesting case of how these patients are going to present to you, but before that we are going to talk about what is called as what is going to be called as a carcinoid. So remember that they have a special feature. ये carcinoid में एक special feature रहता है. They are going to secrete 5-HT3. They are going to secrete what is called as 5-HT3. What is 5-HT3? It is called as serotonin. So serotonin ये टिपिकल इसका फीचर है कि these carcinoid tumors are going to secrete serotonin. तो अब तक हमने क्या क्या देखा? We saw one important thing which was going to be insulinoma. फिर हमने देखा कि पेशेंट को और क्या हो सकता है, मेडुलरी कार्सिनोमा थायराइड भी हो सकता है. पेशेंट को और कौन सा न्यूरोएंडोक्राइन ट्यूमर है तो इट इज phaeochromocytoma. Another tumor which we saw which was gastrinoma and now we are seeing the carcinoid tumor. So carcinoid tumor का एक जो खासियत है, one important thing is it is going to secrete what is called as a serotonin. So serotonin is secreted by this tumor and serotonin के side effects हो सकते हैं. But mind you that when this tumor is going to be present in the small intestine, that serotonin goes to the liver and liver is going to metabolize the serotonin. So serotonin के जो भी problems है तो वो इस patient में दिखने like there are less chances that the patient might present with what is called as a serotonin syndrome. So that is also called as a carcinoid syndrome or also called as a Hedinger syndrome. तो उसके बारे में हम लोग अभी बात करेंगे when we are going to complete this. So first important thing is whenever there is going to be a lesion in the stomach which is going to be a carcinoid lesion which is also a neuroendocrine tumor. So always remember there are three types of carcinoids, type 1, type 2 and type 3. टाइप 1 अगेन मैंने बोला कि सर्जरी में अगर कुछ भी नहीं पता चले तो मोस्ट कॉमन इज ऑलवेज गोइंग टू बी टाइप 1 अनलेस अदरवाइज प्रूव्ड. सो टाइप 1 इज मोस्ट कॉमन. इट इज सीन विद एट्रोफिक गैस्ट्राइटिस. तो हमने वैसे ही गैस्ट्रिन में देखा कि अगर पेशेंट का इफ द पेशेंट इज गोइंग टू हैव लेस अमाउंट ऑफ एसिड बिकॉज पैराइटल सेल्स आर डैमेज्ड देन दैट इज द टाइम द पेशेंट इज गोइंग टू हैव रिफ्लक्स what you can say reflux hypergastrinemia. तो ये पेशेंट्स को अक्लोरहाइड्रिया होने के कारण गैस्ट्रिन भी हाई रहने वाला है एंड द ट्यूमर्स आर गोइंग टू बी स्मॉल एंड मल्टीपल. सो टिपिकली ये पेशेंट को हाइपरगैस्ट्रिनेमिया भी रहेगा एंड पेशेंट को अगर तुम ट्यूमर दिखेगा स्टमक में एंड इफ यू आर गोइंग टू बायोप्सी द ट्यूमर इट इज गोइंग टू बी कमिंग एज अ गैस्ट्रिक कार्सिनॉइड. द पेशेंट इज गोइंग टू हैव डिस्पेप्सिया एंड आयरन डेफिशिएंसी एंड ऑलवेज रिमेंबर दैट गॉड इज ग्रेट. द मोस्ट कॉमन carcinoid tumor in the stomach is going to be benign. So most common type 1 है. Type 1 is associated with पैराइटल सेल डिस्फंक्शन. पैराइटल सेल डिस्फंक्शन के कारण पहले इसमें गैस्ट्रिन भी बढ़ने वाला है. सो अलॉन्ग विद द कार्सिनॉइड ट्यूमर द गैस्ट्रिन इज आल्सो गोइंग टू बी हाई. मैनेजमेंट इज गोइंग टू बी एंडोस्कोपिक रिसेक्शन प्लस पीपीआई थेरेपी. अगर बहुत ही ज्यादा ट्यूमर्स है, एंट्रम में कॉम्प्रोमाइज है तो यू कैन गो फॉर अ गैस्ट्रेक्टमी. बट टाइप 1 nothing to worry, you will go for just endoscopic resection and you will go give the patient PPI. You should give the patient PPI because patient को hypergastrinemia है. अगर patient को achlorhydria है तो PPI तुम patient को side by side supplement कर सकते हो. Type 2 is 5%. So type 2 is comparatively less. MEN1 syndrome is associated with type 1. So it is also associated with Zollinger-Ellison syndrome. So it is going to be associated with gastric carcinoids and duodenal gastrinomas. So gastric carcinoids भी MEN1 syndrome में दिखेंगे. And here mind you that what is going to happen that the stomach is pH is going to be low because parietal cells normal है type 1 में. Because the parietal cells are normal, the patient is going to have hypergastриnemia, hence gastric acid is going to be more and hence the patient is going to have low pH of the stomach. इधर हमने देखा था कि पहले इसमें the pH is going to be high because the patient has parietal cell dysfunction. Here the pH is going to be low and because the parietal cells are normal but the gastrin is increased because of the Zollinger-Ellison syndrome. Gastrin is going to be very high from the gastrinoma and tumor size might be small and multiple. very small and multiple. Malignant potential इसमें भी low है and patient might be having dyspepsia. So यहाँ पे treat the Zollinger-Ellison syndrome, gastrinoma को निकालो and along with that you will go for endoscopic resection of the carcinoid. So type 2 में क्या हुआ? Type 2 में gastrinoma associated है and उसके साथ में patient को क्या है? Patient को there is going to be a lesion and the patient is going to get a treatment of Zollinger-Ellison syndrome जो हमने already देखा कि अगर it is going to be in the duodenum go for resection. If it is going to be if it is the duodenum go for conservation. If it is pancreas go for resection. स्पोरेडिक है तो यू विल गो फॉर रिसेक्शन. अगर इट इज नॉन स्पोरेडिक देन यू विल गो फॉर कंजर्वेशन. साइज लेस देन 2 मोर देन 2 वो सब हमने देखा. तो ऑलवेज रिमेंबर गैस्ट्रिक कार्सिनॉइड्स माइट बी एसोसिएटेड विद योर neuroendocrine tumor, which is going to be a gastrinoma, and type 3 is going to be a sporadic. So there is no gastritis, no relation of gastrin here. It is going to be independent on its own, and it is going to have the worst potential. So it is almost 20%, and it is going to have the worst potential. It is a large solitary tumor with high malignant potential, and here the patient might have metastasis and weight loss. So this patient might present to you with your serotonin syndrome. सर इसमें क्यों दिखेगा सीरोटोनिन सिंड्रोम? पहले तो इसमें सीरोटोनिन सिंड्रोम क्यों नहीं दिखेगा? तो मैंने वही बोला कि नॉर्मली इफ एनी लीजन इज गोइंग टू बी प्रेजेंट इन द स्टमक, so any lesion if going to be present in the stomach, so let's consider that this is your stomach, this is going to be the gastric acid, so this is going to be the carcinoid. तो कार्सिनॉइड जब ब्लड में 5-HT3 सिक्रीट करेगा तो 5-HT3 is going to go down to the liver, so this 5-HT3 will go to the liver and it is going to get metabolized. Now consider that this lesion is going to metastasize, it is going to itself metastasize into the liver, and यहाँ पे अब वो एक कार्सिनॉइड का मेटास्टेसिस आ गया, तो लिवर से ही जो मेटास्टेसिस आ रहा है तो that liver metastasis will secrete free 5-HT3 in the blood, and that is going to cause what is called as carcinoid syndrome. So this is very much important. So carcinoid syndrome क्यों होगा in GI tract carcinoid? So whenever there is going to be a tumor which is going to metastasize to the liver, so that metastasis is going to trigger what is called as a carcinoid syndrome in the body, because liver is not there for first pass metabolism. Very much important for you to know. So type 3 में क्या दिखेगा? Surgical resection, gastrectomy plus oncological management. Because it is a malignancy, here you need to go for what is called as an oncological management. Very much important for you to know. Now mid-gut neuroendocrine tumors अगर रहेंगे तो they might present with carcinoid syndrome. Occurs only and only when there are going to be liver metastases are present, because serotonin has high first pass metabolism. So serotonin normally अगर bypass करेगा liver hepatic vasculature को, तो then that is the time when patient is going to have syndrome, or if there is going to be a transperitoneal primary or ovarian spread. So whenever serotonin syndrome, whenever a carcinoid is present in the gut, it is never going to cause a carcinoid syndrome unless there is going to be peritoneal dissemination or the patient is going to have a liver disorder simultaneously. क्या क्या serotonin syndrome के features है? So flushing, डायरिया, ब्रोंकोस्पाज्म, राइट साइडेड कार्डियल वाल्व फाइब्रोसिस, ट्राइक्लस्पिड प्लस पल्मोनरी वाल्व. सो ये फाइब्रोसिस ऑफ द वाल्व इज गोइंग टू बी व्हाट इज कॉल्ड एज अ हेडिंगर सिंड्रोम. So always remember a Hedinger syndrome, a pet point, a very good point for MCQ. Hedinger syndrome. So what is Hedinger syndrome? Hedinger syndrome is because when there is going to be excess 5-HT3, that is serotonin in your blood, it is going to go to the right side of the heart and going to cause the fibrosis of the tricuspid and the pulmonary valves, and that is the reason the patient might have the cardiac valve fibrosis. It is called as a Hedinger syndrome, and it is very much important MCQ when it is going to come to your NEET PG or NEET SS exams. Left-sided valves are spared. It is because the pulmonary circulation inactivates serotonin before reaching to the left heart. Marker is again 24 hours urinaries, 5-HIAA, and these are going to be elevated, and chromogranin A might also be elevated. Carcinoid crisis, it is a life-threatening serotonin surge, and it is managed with IV octreotide immediately. And cardiac screening is important because heart failure might be there, which will cause post-operative mortality of the patient. So very much important for you to know. So now I am going to tell you a very interesting case. So what is an interesting case? So before going to that, we will first classify the carcinoid. So type 1. So type 1 अगर तुमने देखा तो gastric carcinoids को अगर तुम revise करोगे, so gastric acid को if you are going to classify the type 1, type 2 and type 3, the type 1 carcinoid is going to be associated with small tumors. Small tumors, a carcinoid is going to be present, and the patient is going to have achlorhydria. And achlorhydria की वजह से patient के gastrin levels बढ़ने वाले हैं. Gastrin levels are going to increase. It is going to be most common 80%, 70 to 80%. Type 2 is going to be associated with MEN syndrome, and it is going to be associated with hypergastrinemia. तो यहाँ पे achlorhydria था, इसलिए gastric pH अगर तुमने देखा तो it is going to be more pH. So very much important for you to know, इधर का pH ज़्यादा था, but इधर का pH is going to be less because there is going to be hypergastrin, more acid is going to be secreted. And type 3 is a sporadic tumor, and if it is going to have malignant potential. So it is going to have malignant potential. So I hope it is a take-home point from gastric carcinoids. So इसलिए जब हम गैस्ट्रिक कार्सिनोइड्स के बारे में बात कर रहे हैं, मैंने कुछ भी BLS प्रोटोकॉल के बारे में नहीं बोला, बिकॉज देयर इज नो पॉइंट इन गोइंग फॉर अ बी प्रोटोकॉल, बिकॉज बायोकेमिकली दिस टेस्ट इज गोइंग टू बी नेगेटिव. अगर गैस्ट्रिक कार्सिनोइड है, सीरोटोनिन ब्लड में सीक्रेट हो रहा है, वो सब लिवर इज गोइंग टू मेटाबोलाइज. सो इन द ब्लड इफ यू आर गोइंग टू चेक फॉर सीरोटोनिन लेवल्स, देयर इज गोइंग टू बी ऑलवेज लो सीरोटोनिन लेवल्स. अगर ब्लड में सीरोटोनिन आया, इसका मतलब इट इज ऑलरेडी अ मेटास्टैटिक डिसीज, या फिर कार्सिनोइड इज ऑल्सो प्रेजेंट समवेयर एल्स, जैसे ब्रोंकस हो गया, ओवरी हो गया, पेरिटोनियम हो गया, तो कार्सिनोइड माइट बी प्रेजेंट समवेयर एल्स फ्रॉम वेयर द सीरोटोनिन इज गेटिंग सीक्रेटेड. सो very much important. So one interesting case before we are going to conclude the session. So एक last year MEN syndrome बचा है, one slide is remaining, so I'm going to talk to you about a very interesting case. So what happens whenever there was a patient who came to us with in the casualty with the features of intestinal obstruction. So patient को intestinal obstruction था, तो इसलिए हमने patient को क्या किया, we posted the patient for surgery. So while doing surgery we found out that उसका mesentery was very much thick. The mesentery was very much thick, पूरा fibrosed mesentery था वो patient का. What we did is we found out a segment which was having that fibrosis, a stricture, and we did a resection anastomosis of that patient. Obstruction कैसे diagnose किया? We did it on a basis of a CT scan. So CT scan में दिखा है कि patient को एक transition point है. So transition point means that there is a certain point where the bowel is dilated before and then the bowel is non-dilated afterwards. So that is a transition point. So whenever transition point is present, it means that there is a localized pathology. So you can go for a surgery. If there is no transition point, then you might have to rule out the other causes like ileus or something like that. So there was a transition point. So we operated the patient. After operating the patient, after doing a resection anastomosis, patient was doing perfectly fine till post-operative day 12. POD 12 को suture out करके जब पेशेंट को डिस्चार्ज देने का टाइम आ गया, तो दैट वाज द टाइम व्हेन पेशेंट स्टार्टेड टू हैव प्रोफाउंड डायरिया एंड वॉमिटिंग. प्रोफाउंड डायरिया एंड वॉमिटिंग. पेशेंट का टेम्परेचर एकदम हाई ग्रेड 101, 102, 103 टेम्परेचर पेशेंट का जा रहा था, वेरी हाई ग्रेड फीवर विथ इमेंसिव डायरिया एंड पेशेंट को वॉमिटिंग हो गया. तो हमें लगा माइट बी सम इन्फेक्टिव कॉज. सो इनिशियली वी गेव हर सम लोकल एंटीबायोटिक्स एंड वी स्टार्टेड हर विथ दैट प्रोबायोटिक्स एंड प्रीबायोटिक्स टू द पेशेंट. बट to the surprise, within 2 days the patient deteriorated so much that the patient was shifted to the ICU. Clinically looking, we thought that the patient might have a subclinical leak. So we explored the patient because the patient was not actually in any condition to be taken to any of the investigations that time. So we explored the patient clinically. X-ray किया उसका, तो X-ray में कुछ नहीं था. USG किया, तो there was a collection in the USG. So we thought that there might be some leak inside the patient. So we explored the patient, and to the surprise, the anastomosis was very much doing well. So what was the problem? So that fibrotic mesentery was the problem, and we had missed out a carcinoid in the liver. So it was a metastatic carcinoid in the stomach which had metastasized to the liver, and because of that gastric carcinoid the patient had so much of features. So patient को कुछ भी समझ में नहीं आ रहा. Even post operatively the patient was still not improving, so we were not able to find out any diagnosis. So that is the time when we gave IV octreotide to the patient, and IV octreotide did wonders. Within 10 minutes the patient का fever पूरा गायब हो गया. Within 10 minutes patient का tachycardia settle हो गया. Within 10 minutes patient के loose stools बंद हो गए. We did a CT scan. We found out that the lesion that there was something problem in the stomach, but we couldn't get it properly. To the sad part, the patient landed up into the valvular fibrosis, which we saw. We did a 2D echo of the patient. The patient was the culprit of what is called as the Hedinger syndrome, and sadly the patient was no more after 15 days. So my point of telling is that this happens within fraction of seconds, and patients can be lost within fraction of second. So very much important to keep very high index of suspicion. Any GI tract cause, fibrotic mesentery where you are not getting any cause, because CT scans won't pick up carcinoids. CT scans won't pick up carcinoids. You need to go for what is called as a gallium DOTATATE scan, because that is a nuclear medicine radiosynchography. So अगर कुछ भी नहीं पता चल रहा है, तो then if you are thinking of an endocrine or a PNET cause, you have to go for what is called as, yes, you have to go for what is important, which is going to be the gallium DOTATATE scan. So whenever the carcinoid is going to be present in the appendix, if less than 1 centimeter, appendicectomy alone, 10 to 20 centimeter, depth of invasion देखो, if it is more than 3 mm, you have to go for a right hemicolectomy, and any carcinoid more than 2 centimeter is going to have high prognosis of malignancy, so you are going to go for a right hemicolectomy with D3 lymphadenectomy, because it is going to metastasize to the lymph nodes as well. So pancreatic carcinoids more than 2 centimeters are an indicator of malignancy. So here it is malignancy. So what is D3 lymphadenectomy? So we know that, let's go, whenever you are going to talk about the bowel, we are going to already talk about it. So this is going to be the colon. There are going to be some lymph nodes which are going to be there along the colonic wall. So these are the D1 lymph nodes. So then there is going to be let's consider that there are going to be vessels which are going to carry the colonic blood supply. So along these vessels there are going to be lymph nodes which are going to be called as the D2 lymph nodes. And whenever the main superior mesenteric artery is splitting, so let's consider that this split here, and then there was a second branch here. So these lymph nodes at the level of superior mesenteric artery are considered to be the D3 lymph nodes. So whenever you are going for a radical resection, always mind you that you should go for what is called as a D3 lymphadenectomy. So D3 lymphadenectomy means you are going to remove the lymph nodes which are going to be present at the vascular origin. So जहाँ से वो vascular origin आ रहा है वहाँ तक ligate करने का. So high vessel ligation, so that is called as CVL. What is CVL? That is central vascular ligation. So central vessel को ligate करो, the main vessel को ligate करो, and then you are going to resect off the specimen. So central venous ligation with your D1 with your D3 lymphadenectomy, very much important. So now we are talking about MEN 1 syndrome. Already MEN 2 syndrome के बारे में बात किया है. MEN 2A, MEN 2B, familial thyroid carcinoma, कब उसका prophylactic ये करने का, thyroidectomy करने का, वो सब देखा है. MEN 1 is about menin gene, MEN 1 gene, tumor suppressor gene, autosomal dominant, two-hit hypothesis. Two-hit hypothesis मतलब क्या, जब बेबी जन्मेगा तो उसको कुछ complication नहीं रहेंगे, कुछ तो environmental factor बेबी को होगा, because of which there is going to be the second hit and the patient is going to get the tumor. Penetrance is 95%. So patient को अगर बच्चा होने वाला है तो it is autosomal dominant, so there are 95% chances that the child is also going to have the disease. So MEN 1 is going to be located in the 11. So remember 1 1 1. So MEN 1 located on the 11 gene. The 3 P's, parathyroid, pituitary and the pancreas or GI tract neuroendocrine tumors. So parathyroid is the most common manifestation. It is going to have multiglandular hyperplasia. It is not going to be a single adenoma. We already saw that we are going to go for 3.5 gland excision with going to go for autologous implantation in the brachioradialis muscle. वही मसल को अगर जब हम लोग देखने वाले हैं कि अगर उसको रिकरेंस है क्या, तो उसके लिए हम लोग कैसानोवास टेस्ट देखने वाले हैं. We have already seen it in the chapter. Pancreas is the most common gastrinoma. So pancreas में most common gastrinoma दिखने वाला है. Insulinoma is the second one and there might be a VIPoma. So pancreatic tumor में most common tumor कौन सा दिखेगा? So it might be the gastrinoma, but it is always and always going to have a grave prognosis. The second most tumor is going to be the insulinoma, which is going to be benign, and also VIPoma can be there. Pituitary prolactinoma is the most common and there might also be growth hormone secreting tumor. और इट अगेन माइट बी नॉन फंक्शनल. तो पेशेंट कैसे आएगा? पेशेंट को बाइटेम्पोरल हेमियानोपिया होगा, पेशेंट को विजन का प्रॉब्लम होगा, सो दैट माइट बी द प्रेजेंटेशन ऑफ द पिट्यूटरी ग्लैंड. एंड अदर ट्यूमर्स आर गोइंग टू बी एड्रेनल adenomas, cutaneous lipomas, angiofibromas and meningiomas. So that is more than enough. So how are you going to diagnose? So two clinical components are there or a genetic mutation might be there. So any two clinical components or one genetic mutation. So patient को पिट्यूटरी विथ पैराथायरॉयड है तो क्लिनिकल यू कैन लेबल द पेशेंट एज मेन सिंड्रोम. तो सब पेशेंट के पास में तो ऑब्वियसली देयर इज नो चांस ऑफ गेटिंग अ जेनेटिक टेस्टिंग, उतना अफोर्डेबिलिटी भी नहीं रहता है. तो इफ इट इज फीजिबल देन गो फॉर जेनेटिक टेस्टिंग. इफ नॉट देन यू कैन लेबल द पेशेंट एज अ मेन सिंड्रोम बेस्ड ऑन द क्लिनिकल पैरामीटर्स. 2 out of the 3 things should be present. So पिट्यूटरी, पैराथायरॉयड एंड पैनक्रियाज. सर्जरी क्या करोगे? पैराथायरॉयड में सब टोटल पैराथायरॉयडेक्टमी 3.5 glands are removed, 3.5 gland are removed, half is implanted in the brachioradialis muscle, and always we saw that we are going to go for a thymectomy because the patient might have what is called as a supernumerary glands. There might be another gland, so extra gland might be there in the thymus. We saw that the inferior parathyroids which are going to arise from the third arch are notorious. They are going to go down. There might be a mediastinal ectopic parathyroid as well. We have already seen that in the parathyroid chapter. Go there and revise if you cannot, if you are not able to recall. Gastrinoma में क्या करना है? मैंने already बोला कि less than 2 cm है तो don't do anything, do not resect. If it is more than 2 cm you are going to go for resection. Insulinoma में क्या है? तो first you are going to localize, and if it is going to be syndromic association you are going to go for a distal pancreatectomy. So distal pancreatectomy is only when there is going to be syndromic association. If it is going to be a sporadic, you are going to check for duct. हमने पहले ही देखा है. So if the duct is going to be less than 3 mm distance, go for pancreatectomy. If more than 3 mm, you can go for enucleation. And if any non-functioning peanut more than 2 centimeters, resect because it has a malignant potential. We have already seen all these chapters. And pituitary, cabergoline for prolactinoma and transpenoid surgery for others. So अगर पेशेंट को पिट्यूटरी एडिनोमा है, इफ इट इज जस्ट हैविंग नो कंप्रेसिव सिम्टम्स, इट इज अ माइक्रो एडिनोमा विच इज सिक्रीटिंग हार्मोन्स विच इज प्रोलैक्टिन, यू कैन जस्ट गिव कैबरगोलिन विच इज गोइंग टू सप्रेस इट. So I hope it is clear. With the times permit, we have completed this chapter of endocrinology as well. From tomorrow we are going to start off with very important chapter that is going to be the breast. Hopefully within 2 lectures we will be able to complete the breast chapter as well. So I hope that things are clear. Thank you for your good response for this series. I am also enjoying it because I am able to revise my chapters as well. So let's continue doing this till, how much ever time as I can. After then we'll just take a pause when actually I'll be having my exams. So thank you for attending the class. If you have any problem you can ping me up. I hope these sessions are proving helpful to you too. We'll meet soon in the next module. Just before going, we'll talk about MEN 4 syndrome. It is very rare. So MEN 1, MEN 2 तो देखा हमने. MEN 2A is MEN 2 and MEN 3 means MEN 2B. What is MEN 4 syndrome? It is very rare gene mutations. Phenotypically it is similar to MEN 1, but it also includes renal and reproductive organ tumors. So MEN 1 plus reproductive gland tumors. This is going to be MEN 4 syndrome. Parathyroid hyperplasia, pituitary adenoma plus additional tumor types. Exclude MEN 1 first. MEN 4 is the diagnosis of exclusion. तो MEN 1 तुमने एक पेशेंट को लेबल कर दिया एंड उसके बाद जेनेटिक टेस्टिंग करने के बाद में वो निगेटिव आया, बट पेशेंट को सब क्लिनिकल फीचर्स ऑफ MEN 1 सिंड्रोम है, तो देन यू आर गोइंग टू लेबल द पेशेंट एज MEN 4. So that is a new entity because genetic testing बढ़ गया बाहर के कंट्रीज में, तो उनको ऐसे पता चल कि पहले तो क्लिनिकली भी हम वी यूज्ड टू ट्रीट द पेशेंट ऑफ MEN 1, बट नाउ पेशेंट तो MEN1 जैसा प्रेजेंट हो रहा है, बट द पेशेंट इज नॉट हैविंग द जेनेटिक एनालिसिस ऑफ MEN1. What is that? Then there is another mutation which is CDKNB mutation. So it is most commonly associated with MEN4 syndrome. So I hope it is clear. So thank you for attending the lecture. Meet you tomorrow. Till then, take care. Bye bye and good night.